Hi, good afternoon, everyone. So thank you very much for everyone that's attending, either in person and or virtual. So on behalf of the U of T Anesthesiology and Pain Department and the University of Toronto Collaborative Centre, I'll say a little bit more about that later. It's a great pleasure to welcome Dr. Forbes McGain, which is a visiting professor from Australia, which is a world-renowned expert in this area of environmental sustainability, with a specific focus in the perioperative area. His credentials are all up there. I'm not going to repeat that. I was spending time with him today, and I realized that he actually has expertise in doing things on ground level, as well as leading policy change and advocacy, which I think is an awesome combination to get things done. And before we actually put Forbes onto the microphone, just a few more words. So I just want to wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still the home of many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So just to introduce the Collaborative Centre, is that your true name, or does it have a longer name?
Collaborative Center for Climate Health and Sustainable Care.
Okay, there we go. So Fiona Miller is that's with us today. Is actually leading this new center. It was formally accredited November last year, and it's a new academic unit of U of T, essentially connecting hub, catalyst, and enabler of environmental sustainability in this area. So it's a partnership of 4 health science faculties, and still currently in the process of strategic planning, and I'm sure it's going to be a big role player in the future in this area. So I think that's it. Over to you.
Thank you.
He's going to introduce himself, although I'm not sure if he really is going to do a good job, but let's.
Hello, everyone there. We've got 24 participants out there. That's great. And hello to everyone here. My name is Forbes. I'm the Director of Intensive Care at Footscray Hospital, and that's part of Western Health in Melbourne. And I'm also an anaesthetist there. And I have a new role within the, as Associate Dean, thank you, for Sustainable Healthcare at the University of Melbourne, all in the south of the mainland of Australia. I also mentioned that I am a member of Doctors for the Environment Australia, and a few disclosures that some of my work has led to some patents, actually some associated somewhat to this sort of sustainable area, and also grants from the College of Anaesthetists of Australia and Intensive Care and the National Health and Medical Research Council. And I do want to thank a lot of, I think what I really enjoy about this sort of work is that it is so collaborative. And all along, I've always really enjoyed learning from other people, be they engineers or life cycle assessment like Scott McAllister, other doctors, nurses, infection prevention practitioners, the whole lot. It's always been an interesting process of learning, both as part of my PhD in the area, which now is fading into the distance, but also with ongoing research in different parts, probably particularly engineering, but I also see some roles with psychology of humanity and with implementation science. So what we're going to do, given that it's late in the day, it's going to be a bit of a story, okay, because this is a journey for me, and it's where it sort of started. This is a photo, as you can see, that fixed wing in the background. This is near Uluru or Ayers Rock in Central Australia. I worked with the Royal Flying Doctor Service, RFDS, there back in 2006 for a year, and it was a fascinating experience, but it was also one where I discovered just how resource-intensive medicine is. I mean, we already know that, but I think this really did crystallise for me, that process. And so here's just a photo of the intensive care unit, some of the team there. This is at Alice Springs, which is smack bang in the centre of Australia. like working in Sudbury. But no, it's not as cold as that. But also is that concept you can see earlier in the background. My children are now both taller than me. It was, sorry, you can't actually see the top here, can you? Because it's some, I think probably everyone else, but there's actually writing on the top there. But it was a story of, yeah, it was great doing what I was doing and being a dad and having a family and all the rest of it. But constantly in the background, there's a little homunculus to me saying, but is that enough? You know, what else are you doing as what we do on this planet is quite unsustainable. And so what also got me thinking about climate change was these two pictures. This is from the Lancet back in the mid-2000s. And you can see these warped Mercator projections of the world. You can see United States is very large and Europe is very large. This is looking at the world production of CO2 since the 1850s. What would have changed markedly since this, also as China would have got a lot bigger and India to some extent would have got a lot bigger as well. Because as we know, more than half of the CO2 that's being produced ever by humanity has happened since about 1995. Half of it has been produced since 1995. The other point is that the effects of climate change, even though I think the Canadians and the Americans would probably disagree, is not going to be that small. This is looking at the effects. It's going to be unequally distributed, and that's why Africa looms large, as well as South Asia in particular. The effects of climate change are not going to be equitable. We have the concepts of race to zero, which you might have seen, a UN-related group. But what can we all do to do that? Now, here, what am I doing here? I'm sort of rummaging around in rubbish. I'm wearing veterinarian gloves. I actually started life as a veterinary person. Didn't quite finish my program and failed and ended up in medicine. But here we are venturing through the ICU trash. And you can see the scales on the left hand there. And you can see a little ventilator in the background. It's a story of perhaps a bit like a few of you have been involved in how can we actually look at the amount of waste that's going on and can we do anything about it? I think also my story early on was looking back in 2011. This is a lovely picture of an old Elizabethan hall in the United Kingdom. And these two people influenced me, particularly the guy on the left, David Pension, who was the head of the Sustainable Development Unit before Nick Watts came along. And his role in promulgating the broader picture of looking at the carbon and other environmental footprints of healthcare and how to make it better from low carbon pathways, for example. Sonia Roshnik, who now leads the Geneva Centre for Sustainability, was also, she was the sort of the general manager of the group and was influential as well in me. Now, for those who are newcomers to the story, I know this is sort of well known to some members of the team here, but here's a simplistic way of looking. Whoops, sorry, let's go back there. There we are. Sorry, I just missed that. There we are. On the green, you see here's your direct hospital use of fossil fuels. So in particular, the carbon coming from that is scope 1. And yes, a little bit of that will be anaesthetics, but most of that, in fact, will be gas use. Electricity is the light blue. And in Toronto, for example, that would be a relatively smaller light blue than in Victoria, Australia, for example, because we use mainly coal, whereas you use mainly nuclear and hydropower. But scope 3 then is the big part of the story for medicine, which is all the stuff we use, everything from a little syringe to a new MRI scanner. That all becomes part of that story. And there are some little hotspots within there. I know that some of you already know very well that metered dose inhalers are part of the story, and they have their propellants are problematic, but it's much more than that. This is a much bigger, more wicked problem of climate change. And as we know, the story of the carbon footprint, I know that Andrew McNeil and Jodie Sherman and Matt Heppelman have published similarly in Canada, that the carbon associated with Australian healthcare is about 7%, the world is about 5%, and I think Canada is around about 5% as well. So it's not nothing, it is important. It's not necessarily the most important part of the economy to change, but I think also the important point is that we can lead here instead of being laggards. We can actually lead here and show other parts of the economy, whether it be it agriculture, be it mining, be it industry, to change their ways as well. And in fact, it's quite interesting when you think about it that, drive along the street in 10 years' time, it'd be good to be able public transport, I agree, but the electric car revolution is going to be pretty fast. I think the changes in hospitals are actually going to be slower unless we actually make a real change as well and are involved in changing our economy, as it were. I think the other important point of this little slide with Alex Barrett, who's a public health physician from Sydney, I've been doing some work with, is looking at, you know that circle on the left-hand side there, it's a number between 60 to 80% is all the stuff we use, 20 to 40% is the energy we use in hospitals, that's the carbon footprint of healthcare. But on the right-hand side, you can see the traffic light sort of system there is, the green is all of the things that we should be doing in healthcare. The orange is, wow, that's low value care, probably not very useful. And the other 10% is actually harmful care that we do. Now you say, where does that come from? Where does this story come from? There's been a number of studies by public health physicians over many years, actually, that say that it seems to be in that sort of range, that literally only about 60% of medicine is actually useful for patients, and the rest is either low value or actually harmful, mainly low harmful. So what we're going to do is get rid of the red. We've got to squeeze down the amber, and we've got to green the green and actually make it green. And that story, I think, needs to be emulated. So next slide, there we are. So here we are, here's our operating room. The only thing you see there this is not orthopedics. This is the only thing that is not wasted there is the stainless steel you see in the up top left-hand corner. Everything else is thrown away. Sometimes things are very expensive. At least in Australia, these are a few $100, these ligatures. And all the other things you see are disposed. Now, this is not the same for all operating rooms. This is looking at a lap collie you'll see in Melbourne, Australia, and where I work. And so you see reusable gowns and reusable drapes, and you see reusable plasticware. A lot of these are thrown away if they're not in the reusable sort of setup. And it is, yes, this blue wrap, as you know, is the universally used chuck away. But that is just giving you a bit of an idea that it doesn't always have to be that way of having disposable anywhere. I'm not necessarily going to say that this is a story all about gowns. I know we've sort of talked about them a lot, but I think we're very visual creatures. And I think once you start that ball rolling, it's a non-linear process, as Courtney Howard would talk about, that it's not a linear process of change here. Once you've got one thing into the system, it can actually lead to a non-linear change in many other things. Also, what I got involved in early on, and I'm not here to sell PVC recycling because I don't think recycling is a big part of the story, but I'm giving you my story of how I started here. It was exciting to be involved in this project, once again with the recyclers, with the Vinyl Council of Australia, no, they don't make records, and also with the actual manufacture of these items to turn your intravenous pipe, intravenous fluids, your face masks, turned into agricultural pipe in Melbourne, and there's now about 150 hospitals in Australia and New Zealand doing that. So that's quite exciting. New Zealand has their own company doing good work there, but it's exciting to have Baxter involved in that process. And I know that that's happening now. A little shout out to Dr. Ali and the rest of the team all involved in that there. So well done. And I think that this is a story where we have to work at multiple levels. You know, we have to do everything. We have to now do everything we can where we can. And so I think this is an example where something that we can't really do that much with, you know, PVC plastic once we've used it, it's either going to get chucked away or it's going to get recycled. And so it's nice to have that process. Look, I'm going to quickly get through this. So you already know this story. Part of the story was that when I started, and probably from reading articles in 2010 through to 2012 about this process, that desflurane is a bit of a problem. We shouldn't be using it in anaesthesia, and that using 1 hour of desflurane is like literally 2 days of cyclofluorine in terms of its global warming effects. And it's like burning 30 litres of petrol per hour. I know there's some controversy that has come through from the Dame Slingo and the team in the UK about this, because desflurane is a relatively short-acting agent. It's not long-acting like carbon dioxide is, or even nitrous. However, I think in the end, well, all of these things have a global warming effect, regardless of what discussion you want to have about it. So I think it's easier just to move on from this and then get on to the big picture, which is nitrous to some degree, but much more importantly, carbon dioxide. You already know the story that essentially desflurane has disappeared from the United Kingdom. I do think, though, just finishing with the nitrous story is quite interesting, because I think this is the first example where a drug is no longer used from an environmental perspective. It's actually never happened before in the history of medicine, that a drug is not used now because of environmental effects. I actually find that an interesting story. And furthermore, we can actually trace it. So here you can see the desfrain use. This is data from Martin Vollmer and his team in Switzerland, and also with international collaboration in Australia, Korea, Antarctic stations, for example. What this is showing is this story of desfrain. Sorry, where is it? So you can see the story of desfrain up to about 2012, 13, it's still going up and up. And then it's sort of peaked and it's starting to come down. It'll be very interesting to see the next few years this change. You can also see the other reason why we know it's starting to come down is this blue number, which is Antarctica, is getting close to the orange number. In other words, because there's not a lot of anesthetics happening in Antarctica, it's drifting down there. And if that number starts to approach what is coming down to it from the north, then it means that less is being produced. So that these numbers, you can see that natural story of the blue approximating the red with time, whereas they were separated it on because it was drifting down from where it was coming from. A bit like CO2. I mean, I don't know, I'm breathing more CO2 here than what I do in Australia normally, because this is where most people live and produce lots of carbon. Really interesting story about parts per trillion of things. We can measure what's going on there. The other thing that I've been involved in for a while now, I suppose, is the story of nitrous oxide. A very different story. And it's really interesting to see, and I think it's just begging to be done, a survey, maybe through the World Federation of Society of Anesthesiologists, looking at what we actually use for nitrous oxide around the world. Because in Australia, more than half of all births we use nitrous oxide for. Some go on and become epidurals. But the point is that that's very different to, say, somewhere like France or the Netherlands or Canada, as I've only really just discovered today. So I think that that's a really interesting story. Essentially, what we found is that Melbourne and Sydney are about a bit under 1,000 kilometres away. By a 4-hour labour, for a woman, you're producing about the same as driving in a car, about 1,000 kilometres. Very different to the epidurals or other things that you would otherwise use. What I would say is this is a touchy topic. It's one you have to tread carefully at. I think it's one that's going to involve, it's much more complex than desfrain because it involves other providers. It involves, how does this change gradually? How are the perceptions of nitrous oxide being a natural thing? Isn't it fascinating to know that cultures are very different in Canada versus Australia and the use of it? That's a gradual process. So a long story. I won't dwell on this one too much more, but the other thing is to shout out to all the good work from people in the UK in particular, Olivia Chikera, and some work, and just the waste of nitrous oxide is another really big part of the story. We were wasting more than 70%, and in some places it's well over 95% is wasted. And so I think that story of a gas is wasted often, and so we don't worry about it so much if it's oxygen, but if it's nitrous oxide, then it becomes suddenly a big problem because it's got its own global warming potential, about 270 times out of CO2. Now, one of the other things that I've been mainly involved with, this is that cartoon of life cycle assessment. You can see when you've got to study something, you've got to know where it's coming from, what it's manufactured into, how it's packaged and distributed around the world, how it's used. It's either chucked away or it's actually reused, and maybe it's recycled. So it's that story of stuff. What did we do? Well, one of the earlier studies that I did was actually a comparison in 2 hospitals, as I sort of alluded to. So you can see some reusable face masks, reusable laryngoscope blades and handles, and reusable circuits that we use in anaesthesia, all common boring sort of stuff. And then comparing it to a photo, I won't show you a bit of the disposable equivalent, which I've just seen some of today in Sunnybrook. Reusable here, but disposable here, for example, and disposable over there. And so what we did was just had a look behind the scenes. When you do a life cycle, you need to know what's going on and how much money it costs to pay for this person to reuse things and to reprocess things. And you've got to set it through a washer, and you've got to put these laryngeal. This is in the old days, you see, we still had reusable laryngeal masks then. Mm-hmm. Sadly, that has changed over the last. That was one where we couldn't win on because it was just hard to procure these things actually over time. So interesting to see how that changes. You can see the wrap. There's a lot of this. You may not see so much of this in Canada because this is, although it's changing now, it's exciting. So this is your reusable gowns all wrapped up in here in a sterilizer load. In fact, most of this load I can see is reusable gowns. This one, you can see that's a standard sort of surgical equipment down the bottom there. And you can actually see, I can pick that one's going to be reusable bowls, for example, the plastic bowls. So there's a combination load that's going to go into steam sterilizer. This is the back of the steam sterilizer. That's all wrapped up in silver in order to keep it nice and warm, keep the cooker going, because you've got to keep it nice and warm. We hooked up a Wi-Fi and ran 1,000 runs of the sterilizer and looked at what its energy use was, because I wasn't going to sit there for 1,000 runs, all part of the PhD. So what do we find? Well, what is interesting about the story, again, is that story of, okay, here's the reusable equipment. The numbers don't matter too much. It's more the problem of having your source of energy is coal, and in fact, slightly higher even than the disposable equipment down the road. The carbon footprint was higher because of the source of energy. Very different to the United States. So you can even see that the blue here for the United States has a much lower footprint if you were to use reusables. Not that many actually do use reusables in the United States. I know Seema Gandhi's changing that in the USESF, and it's exciting. So pockets of excitement is happening. But in Europe, that's why it's green, they have a much lower story. I suspect Canada will be more like this because you do have a lot of nuclear and a lot of hydro. And so having a reusable equipment is certainly going to be better if you're based in Europe and Canada, and in fact, quite a few other places. Our problem is that China has a carbon footprint associated with its electricity grid very similar to Australia. And that's the real problem, because there's only 27 million Australians, but well, truly more than 1 billion Chinese. What is exciting, though, is that story that we're moving towards renewable electricity very quickly. And in fact, at the end of next year, we'll see, we'll have to hold them to account. But the idea is that renewables will make reusables better, because you'll be using reusables with renewable electricity. So I think there's exciting times ahead for Australia. We really are getting on the wagon now at last. And the generation of renewable electricity with batteries and all the rest of it, buckets of solar and quite a lot of wind is all underway. The other little point, I'm just going to do a little aside here, is this story of, this is what you call a process diagram. And up the top here, you can't see it, this is actually polypropylene, for example. A very common, so you can just imagine your bottle here. And that is the manufacture of it. What you've got to do for all your products when you've got a life cycle assessment is to look at, well, where are things coming from? What are the proportions? And unsurprisingly, for polypropylene, there's propylene as the base. And this is the manufacture occurring either actually see Botany, that's obviously Botany Bay, Sydney, New South Wales. And you can see the production of that. This one is actually Altona, which is Melbourne. So as you can see the detail that's coming through in the system to produce, this is the big part of the story, is the feedstuff for the polypropylene is natural gas or fossil gas, I prefer to say. And so you can't really change the source of that, well, the source of that. So even if you use renewable electricity for your disposable plastics, you can't change the carbon footprint too much, because most of it is the feedstock that feeds into it. That's a part of the story. Even if you go 100% renewable electricity, you're only going to change 20% of the story. So I think that's a really, you've always got to be your own devil's advocate when you're doing these sort of carbon footprinting and stories, to think, we'll always just think, well, what if I did it the other way? What if we still chucked it away, but it came from a renewable electricity source? Sadly, that's not going to really help things. Well, we could use bioplastics. Well, that's another problem in itself. I can assure you, the corn farmers of Iowa will be not necessarily doing so well at that, because that corn farm would, feed lots for pigs, for example. So you're taking it away from them, and so there's all those stories, or even corn as maize meal for human consumption. So it actually doesn't really make sense to be using. That's why we haven't seen so much of a story about biofuels. It's all sort of died down a bit there, because it's actually quite problematic. This was our next study that we got involved with. Am I going too quickly? Is everyone still enthused? We're still enthused. Okay, no one's screaming from there, but there's no snoring from the participant. We wouldn't hear anyway. They would have turned it off. The carbon footprint then of general. I really like this picture. This was Marike. Sorry, I forgot her surname. The Dutch lady who had a breast surgery, and this is all the stuff they use. So I remember looking at that and thinking, my goodness, the Dutch are really wasteful. I thought that was really good. We were having a chat about this this morning. And so disposable gowns everywhere, disposable gloves, of course, which are often the bane of our lives, and a lot of other disposable equipment just used for, I think, a 2 or 3 hour operation. So what we did was look at a total knee replacement. And for me, I think the exciting part about doing these carbon footprints, environmental footprints, isn't so much the actual doing of it. It's actually finding surprises all the time about this. There are a few things that really surprise me, because you think, well, surely if I'm putting a spinal in someone's back, that's going to be a lower carbon footprint than doing a general aesthetic, because I'm not doing all this stuff. But it's also the problem that when you do a spinal, it's the whole output is, what is the patient care level here? Well, we still need to have a warmer. We still need to have, for example, in Australia, we have to use reusable plastics and gowns and all the rest of it. Or you can have disposable variants. You've got all this single-use stuff still being used for the orthopedic surgeons. There's the drugs, the carbon dioxide as well. There's oxygen. And so, unsurprisingly, for the general anaesthetic group, there were 10 of them. You see that sevoflurane is important. You're seeing a lot of single-use stuff. And you're seeing really the electricity for the warmer. And that's really interesting, isn't it? You sort of say like a quarter of the total there is actually just the warmer, the bear hugger. And it's not the bear hugger per se, it's actually the warming of it, because you're using coal-fired electricity to warm the patient up. Different matter. So you'd imagine, to put it into practice in Toronto, for example, this red would be much smaller. This will probably be a little bit smaller as well. I imagine this will be much the same, if not maybe slightly bigger. This won't change too much, that won't change too much, and you might be using TIVA, for example, and that'll probably be really low as well. So in fact, you could probably halve your general anesthetic footprint. I don't know, have a little think about that one. Spinals though, what's really interesting, of course, is the oxygen over here, because some of my colleagues were running 10 litres a minute of oxygen because they said it's good, more is always better. The SATs are 99 or they're 100. And then it's sort of thinking about, well, how do we change that behaviour? Because that is actually it's an example of low value care. It really is a low value example. It's something that's wasteful for the environment. It's wasteful for costs. And it just rolls on because it doesn't harm people really. It's just harmful from a broader point of view. It actually contributes to climate change in a very small way. I think the other important point, as I was chatting with Anita about, was a little while ago, like we use gowns for all our spinals. And then I'm thinking, oh my goodness, the rest of the world doesn't seem to do this. What's going on? And then you have to talk, wow, we must have gowns for our spinal anesthetics. Otherwise people are going to have meningitis. And so it's really interesting to think these sort of cultural factors coming into play about why we use things and how to change that. So that's where I have to bring in the rest of the team, because I can't do this alone. So it's going to be really interesting over the next few years to see if we can change that culture, change the guidelines that the College of Anaesthetists has, which were very clear. You wear a gown when you're doing a spinal anaesthetic. We need to change that. And so they'll be important to be part of that process. Look, that's just a combination of the GA and the spinal together. I don't know if you do that too much, where you run the two, because then you really know it works.
Not routine.
Intentionally.
Yeah, not intentionally.
So that's really interesting, isn't it? Isn't that really interesting? So the combination, you can see, look at it. I mean, I'm not making this up. Like we easily enrolled, 10 patients who had the combo. Anaesthetists know best. Okay, so that's it. So I'm going to move quickly on to a few of the other topics for those in the audience who may not be so much anaesthetists or surgeons, but I think this is something that's relevant to everyone. The carbon footprint of pathology testing, we were a little bit surprised that it hadn't been done before, because it's such a big, we're talking about millions of these tests every day. And I know that there was follow-up work from Andrew McNeil, who's done a similar sort of study recently in this area. And so what I'll be saying is that if you do a full blood, what do you call this, a CBC or?
Complete blood count.
What is it? Complete blood count. Yes, complete blood count. So one complete blood count is like driving an average car in Australia, which is similar to Canada, about 3/4 of a kilometre. Okay, so it's not very much. It's not very much. But the problem is how much you use of these things. So we just quantify things. Why is everyone always asks this, why is the C-reactive protein so low? It's because it's always added on to something. So it's that talking about, I won't go into the details of consequential versus attributional life cycle assessment, but if it's an add-on test, then it costs money, but it doesn't cost so much from an environmental point of view, because it's often just adding a little bit to whatever you're doing anyway. And so C-reactive proteins tend to be just added to urea electrolytes in Australia. That might be different. If you're doing that by itself, it suddenly becomes almost as much of that by itself, because you have to bleed, you have to use a tube and all the rest of it. What I wanted to say quickly about this story was very much pathology is not about, so I was talking about reusing, prior story, reusing versus disposables. This is about reducing. This is all about, you're not going to be reusing blood-filled containers for pathology or plastic. That's a much harder job. You should just be reducing how much you're using in the first place. those pre-op testing, doing any clotting profiles, etc. So I think that that's a really interesting point. And I will just digress a little bit. The arterial blood gas one is really interesting for an intensive care physician. Is, my goodness, the nurses use, it's almost like a crutch to have a blood gas, because it's sort of like those behavioural factors come into play. We obviously overuse blood gases. We're doing them all the time. They're able to be done by nurses without involvement with doctors, and so they get used willy-nilly. And so there's multiple levels at which there can be changes. It's about avoiding diverted care. Just as a quick aside, then we moved on to radiology. There was some good work by Michael Overcash and Janet Toomey in the past from Wichita, Kansas. But we followed on with a study looking at MRIs and CTs, and you can see it's quite evident. What does this mean? 18 kilograms of CO2 for an MRI. I'll just focus on those two bars. It means that it's like, you have litres or gallons when you deal with your petrol. You have litres, so not so much air. So we're talking about 8 litres of petrol is one MRI scan as an average, And a CT scan, interestingly enough, is about 4 litres of petrol for one CT scan, which is interesting because you can do many more CT scans than you could do MRIs for at least half an hour each time. So you can't cram them in so much. So in fact, it's probably CT scans which are the bigger one problematic globally, simply because there is more access to them. I know you have to wait a year if you're an outpatient in Canada. No, you don't, sorry. But you do in Australia sometimes. But I think the important point is that both of them are really quite important. When you're talking about X-rays and ultrasounds from an environmental point of view, not from a money point of view or access to care point of view, they're not really so important. You really have to do a lot of them to actually make the same effect as having a CT or MRI. The other one I wanted to quickly talk about is drugs. Really big part of the story, drugs. Pharmaceuticals. This was a study we did quite recently, led by Jess Davies, from an anesthesiologist from Melbourne, who's very much now into implementation science and trying to change people's behaviours with reusable and disposable equipment, rather like what you're trying to do here. Just in a nutshell, looking at the comparison between a bit of tablet of paracetamol versus an intravenous glass vial or plastic vial, you're talking about a 10-fold difference in the carbon footprint. You're also talking about at least a 10-fold, actually more like 100-fold difference, at least in Australia, costs. And so, it's so hard. And what we want to be able to use this now is to use this as a pre-op setting. And part of the problem in Australia is it's just very difficult to get people in time to get their oral paracetamol in before they come to theatre as a preoperative sort of care of the patient. And getting them to take them before theatre is quite difficult often because English might be second language. And so it's just really seeing how complex and wicked this problem is, even with just one medication. But what I'm saying is there is no silver bullet here. There's going to be multiple little efforts along the way to change things. I bring that in, so now we've covered pathology, radiology, and just one drug in pharmaceuticals. The problem with this, you can see, like we've just sort of, yes, we have to deal with nuclear medicine. It's another research project we're on to now. That's going to have its own headaches. Working with the nuclear physicists, because Australia only has one source, really. It's Lucas Heights in the south of Sydney that sort of basically distributes all the nuclear medicines to the country. And so you have to work with them. So you can imagine the amount of security is quite large. And so that's exciting. But what I'm going to say is that for pharmaceuticals, it's really hard because there are thousands of pharmaceuticals. And a lot of this is hidden or opaque or uncertain. And, we have looked at morphine, for example, because half of the world's morphine and buprenorphine and oxycodone it comes from Tasmania as an origin. So south of a little island, it's a nice safe place to have poppy fields. There are other illicit sources of such goodies around the world, but the world's licit supply of these drugs, these 4 big drugs that we use, actually come from Tasmania. Then they're sent around the world. Yeah, so it's a big producer of such medications. So we did another. I haven't got time to go through the detail, but it was a very interesting process of the bouquet of those poppy fields were more than the wheat fields. Okay, I'm going to move quickly through this because what is the time, team?
5:37.
So we've only got maybe another quarter of an hour, I suspect, because we do want to have a bit of a chat afterwards and answer questions. So look, I will flick through this part pretty quickly. This is the ICU part of the story for anyone who's out there who's an intensivist. This is some good work initially from Adam Pollard and his team in the UK. What this means is they looked at all the stuff, the ventilators, the computers, etc., the renal support machine. For one patient, that's about 15 kilowatts a day. What does that really mean? I know Canada will be using more electricity than we will because it gets pretty cold here. But it's like a 2-bedroom Australian house. I suspect it to be probably, you're probably burning quite a bit more than that over the course of a year. And that's taking into account gas. I've just converted the energy into a kilowatt hour rather than megajoule. But that's, so in other words, it's sort of saying that one ICU patient, just from their ventilators and things like that, is similar to one 2-bedroom household. So it's sort of somewhat important. You can see some numbers there. They're actually relatively small numbers. That's the first thing. These are not big numbers of what's being used. Also, even over here, you've got your renal support. And like even when you look at something like, it's sort of interesting, it's surprisingly enough, the humidifier uses more energy than the ventilator, or almost double. And that's because you start to heat things. And so it's a story of, it's not what you see, but it's what you feel that starts to matter from an energy point of view. Feeling as in cool, as the engineers would say, cold, or warmth. And so we went on, and this is my links, I suppose, with St. Louis, Missouri, Jason Burnham and Maren Koloff, looking at what is the actual footprint of the intensive care unit for treating patients with septic shock. So we ran around and went slightly mad, and we measured everything that was being used for that patient, everything from the syringe to, oh my goodness, they're going down for a CT scan, we better work out what's going on there. So it was actually very, even though it was an observational study, in a way it became much more like an interventional sort of study. We didn't intervene or not, but it felt like it. And we looked at patients in St. Louis and Melbourne. St. Louis gets pretty cold in winter as well. It's very hot, as I've noticed, in summer. And so you've got more extremes, and that's really important because we're all at the peril of our own geography. We looked at everything that was going on there. The answer is complex, but what I would say is if this is a percentage, the numbers don't matter too much. It's more to say that the carbon footprint for both ICUs, the blue being St. Louis and the amber being Australia, Melbourne, you can see that, interesting enough, it's the energy that's important. And this is a different story to what you sort of hear about the global picture of healthcare being, most of it being stuff. But in the ICU, it seems to be different. And so I think that would be interesting. I think there's a lot of research work that still needs to be done, looking at different parts in a more nuanced way of what's going on in the operating room, or what's going on in the ICU, what's happening in the cath lab, etc. Where is the footprint going on? It's not to say that all the stuff we use is not important. It still is. And in Toronto, as I was saying earlier, I suspect that the story is a bit more that all these will get bigger and these will get smaller because your source of electricity is different. However, there's still gas for heating. So maybe it isn't that much different. And we're talking today to the CEO of Sunnybrook, and he said, I wouldn't have a clue how much of energy actually comes from gas versus electricity. So it's just that story, I think, it needs to be worked out in more detail, and it's an interesting one of where things matter. Because although we could all be working on all sorts of different things, I think it's important to try now. We need to start focusing on the big things, and there'll be about 10 or 20 of them that actually really matter to each of us. We'll move on. So, it's okay. Gas is a problem. I'm going to quickly move through this one. Just to say, as a little aside, I was intrigued by this story. We don't make many pharmaceuticals in Australia, and yet we were paying much less than the Americans were for standard, noradrenaline and common or norepinephrine and other medications, standard ICU medications, than the US was paying. And it's interesting, you would think that in a highly competitive world in the US, you'd be paying a lot less. But no, it's not the case. Look at Fiona Miller screwing her eyes up there. So I think it's really interesting. Also, even the pathology testing, you look and see it's almost like 4 times as much per day. Now, is that because they're ordering more, or is it because it's costs more per unit of things you're ordering? Bit of a combination when we looked at what was going on with, say, noradrenaline use, for example, because that's not really going to be very different between patients, in Australia versus New Zealand. If you've got septic shock, you've got septic shock. I'm going to move on quickly from this one. What I want to show you, this little picture sent to me by Eleanor Dam, who's from the UK. What is going on here? So this is the Orkney Islands. So this is at about 60 North, and they have their first fully electric hospital, and so you can do it in quite non-mild climbs. Yes, they're by the sea, so that does mediate the temperature a bit. It's not like being in Winnipeg, but it still gets very cold, and it certainly does snow there every winter. So they can get away with having a fully electric hospital, small one, but it's to say that it can be done. I just want to finish up with a bit of COVID-19, because I think in a way we've missed our opportunity for COVID-19. And I think it was a great, but I want to give you a good news story where we did make some changes that were positive. This was looking at, well, what from our opportunity have we learned here? What were the effects from an environmental point of view? What you see here is the standard nurse wearing disposable gowns when 2020 hit. And we did a survey across Australia and New Zealand Intensive Care Society, a point prevalence program, because we decided it'd be nice to work out what is being used. And so an average nurse, not that there is an average nurse, versus on an average day is using about 20 of these disposable gowns per shift. And about double that in gloves, obviously pairs, and they're all being chucked away. And on average, you might be using this for a few minutes. What we quickly worked with the infection prevention team is to say, well, part of the story that came out there was we developed a sustainability guide to the ICU. Thanks to Louise Trent from New Zealand, who led this with myself and the rest of the team, and looked at what we could be doing here. And so this story was one of, I found it quite an interesting one. This is a GP, it's Kirby White, a GP, general practitioner, a family medicine doctor from Bendigo, which is in the country of Victoria. They couldn't get enough disposable gowns, so they moved to reusable gowns. The seamstresses started making them. We as in Sam Bates, who's the ICU research nurse at Western Health, myself, went and visited and said, well, this is exciting. At least you can still see your patients. The local laundry service is still being employed because they weren't getting their usual business because everyone wasn't going anywhere. There were no parties, not legal anyway. And then so the employment was good. And Gowns for Doctors was born for that. So a nice little group of the general practitioners around the country will now have Gowns for Doctors. Kirby got a Victorian State Award for that. So we said we're going to emulate this now. I'm not as attractive in this item. There's no multicoloured iridescent nature of the gown. We were using those disposable gowns, we were using about 1 million per annum in 2020, 2021. We then went to reusable gowns, importantly with Marion Kainer, the head of the Infectious Diseases Service, Infection Prevention. So it was great involving them. We just did a one-to-one swap. So it wasn't like we were completely getting rid of our footprint by any means, but it was exciting to see that process working with the linen services, cost neutral, most importantly. And we did a little study of comfort. So actually what this got us over the line was actually the nurses preferred it because you didn't sweat as much in the polyester versus the polypropylene. Over here you can see a reusable gown being used by the resident. Yes, I should be observing him rather than being photogenic. And he's putting in a central line over there, and that's a reusable gown. We've moved on from that, and we're now using reusable other sorts of things, which is exciting. Just as a little aside, and this is sort of intriguing information, is that these we're discussing it. So what do you call them again? These are the disposable.
We started calling them blueies after the Australian practice the blueies.
Okay. So the blue pads, disposable ones, most of them use that. We're now moving we've moved to reusable in our ICU and now the operating room. And what I got excited about is it really didn't have too much to do with me. It's actually the nursing staff who led this. And so it was like an environment of agency, is about the story. It's like, Forbes is really interested in this, and so we can go and do this. And so it just goes on and, blossoms. It gets exciting. And there's your pinkies, which are the larger version of these ones for, well, let's just say more stuff. And what we converted to was, it wasn't just what I got excited about, and we just have to qualify this and see, certainly it's worth writing up if it's real. It looks like the actual use of these greenies compared to the blueies before, which are disposable, is about half. And so it's almost like there's that behavior change. We didn't actually need to have two of those. We now use one. So it's like you've actually gone to reusable and you've reduced it simultaneously. So it'll be interesting to follow that up and see where that's going, because that's actually really exciting behavior change when you're actually halving, because to me, it's really upstream. It's about reducing as much as possible. And so I just mentioned that as a moment, that if you use, it will depend on which country you're living, but in the USA at least, if you use a disposable gown, you're driving an extra 10 kilometres at work. One way of thinking it. So that's work from Eric Batzola, who's and Michael Overcash, who have been long-standing champions in this field in life cycle assessment, particularly in reusable versus disposable linen wear. I do think, summing up, that a lot of this is, well, all of it is collaborative, and I think there is a. I think that involving infection prevention is incredibly important early on. Yes, there will often be resistance to this process, but I think that a lot of that it comes from a place of where this is the world that I'm used to, and the world is working just fine. Thank you very much. I don't have to worry about that externality, which is waste, because that's not my job. My job is to make sure that patients don't get infections, particularly nosocomial infections. And it's working with, okay, how can we start to see that process change? So I think involvement in infectious disease, infection prevention is important. I think also, just similarly, I think that engineers, there is engagement, but often what they're dealing with is a day-to-day, headache of people complaining it's too hot in the operating room, it's too cold, and they're on the phone bleating about it. My colleagues, and so they're dealing with these spot fires burning all the time, or the fact that the night engineer hasn't turned up. So someone has to staff, so there's all those usual headaches that they have to deal with. So their concern is if it ain't broke, don't fix it. As we say, I don't know if that's a Canadian expression as well, but ça va bien, as they'd say in Montreal, everything's going fine. Well, it isn't really going fine if you're just actually leaving these air changes at 20 per hour running continuously. And so I think that's my other big area that I really want to get involved in. So I think there could be real opportunity for engagement there. And I do see some good things happening in the US as well in that area. So that's exciting. I think and I mentioned Cape there, and as well as you're learning more about Toronto and what's happening here. A nice, maybe like a really depressing little book there. This civilization is finished. I don't know why it has those colours on the can. But Rupert Reed and Samuel Alexander, it's a nice little sort of philosopher's view of where we're going. That really, when you take a step back, that you have to accept that our current trajectory is actually quite unsustainable. I mean, we sort of know that, but this is a philosopher's view, and it actually really is quite an interesting one. And then we need to change. And so what it means by this civilization is finished is literally this civilization now is finished, because we either have to get through it, this bottleneck, and blossom again, or we're all in deep, deep strife. So we have to make that choice, because this civilization right now is finished. It doesn't mean it's going to end tomorrow, but it means that it will end at some point, and it has to change. And so I think being part of that change is actually really exciting and empowering. And I think that we have to get past this bottleneck. Enough of us must do what is necessary to see a brilliant future in medicine. Thanks for your time. Okay. So I'll step back a bit.
Sure.
Take a drink of water.
So I'm going to ask people to post in the chat, please. I'll be moderating the chat. We have about 10 minutes, maybe. If folks is okay, we can go a little bit over time, because they
I'm here to work.
Sorry?
I'm here to work.
Okay, good. While we're waiting for the chat, is there anything in the chat so far? We can actually, anything from the audience.
I have a question. Thank you, Forbes.
I hope it wasn't
A great overview of your journey, and I hope it continues as such.
our journey.
Our journey. Speaking of our journey, so we met you at the World Congress, and we spoke to a few people like-minded, and we here at University of Toronto, massive program with how many hundred listeners?
558.
There you go.
At the University of Toronto,
Affiliated.
That's about
It's huge.
20% of the whole.
And with a strong community representation and academic. And at the World Congress, we ran into some people, now I can't remember, who or heard about fellowships in sustainability in anesthesia. do you have
Yeah.
experience with such? I sit here as being non-academic, sitting out in the West End, community person who does some of this work, but I'm thinking, wow, wouldn't it be great to someday have an environmental sustainability fellowship at University of Toronto?
Yeah, so, great question. So what I would say,
Chairs here.
And the
so-
chair.
Yeah. Sitting right next to her, sitting right next to her. She
so,
knows more about this stuff than I do.
yeah, what I would say is that, yes.
Road bumps along the way.
Yeah,
do you have experience
great,
with
great
this?
question. So it's really good for me, truly being sustainable is when I don't have to do it. So Nicole Sheridan, actually one of the anaesthetists, is now running sort of in charge of that. We've had a couple, but it has been not continuous, unfortunately. So that it depends from year to year what the enthusiasm, not from us, as in Western Health is, but rather from the actual candidates themselves. So what we tend to do is, like in the final the 5 years of training for anesthesiology, there's a fellow year, and you can choose to do, you can simulation or regional anesthesia or cardiac or whatever it happens to be. And so you can see most people tend to choose something that is a practical, as in deeply practical point of view, like becoming a cardiac anesthesiologist, or I want to become a regional anesthesiologist, or I have a special interest in that, or obstetrics, or what happens to be. So that you're competing in a sense with people who want to do that rather than doing environmental sustainability in anesthesiology. And so it has been intermittent. We had our first, Emily Belmax was first, that would be 3 years ago. We had one person after that, but we haven't had someone in the last 2 years. So it's quite variable. Yeah. Have there been other people? Not that, and it is a question that we're asking amongst ourselves, not that we know of in Australia, but what I would say is it's very much established in the United Kingdom.
Yes.
That's what I mean.
So I know, so like Kathy Lawson from Newcastle upon Tyne was the first one, I think, to do it, and that would be 8 or 9 years ago now. And I know different hospitals are now doing, like there would be simultaneously maybe 4 or 5, I think, in the whole of the UK doing this. There might be slightly more now. Anaesthesia is there, renal physicians are doing one, psychiatrists got one, and I'm pretty sure surgery's got one. So certainly I would say that it's a combination of the Centre for Sustainable Healthcare led by Rachel Stancliffe have sort of been involved with that. They're the ones who do those carbon footprinting courses, which you did, but also the Greener Healthcare group, now under Chris Corley. I don't know about other nations.
I'm just going to go to the chat.
Yeah.
So there's one question from Ian Randall. Can you foresee life cycle assessments being part of a practice of?
Yeah, okay, really interesting. Great question. Sorry, thank you, Randall. Ian Randall. So I think we're starting to see that, as Fiona and I were talking a little bit. So there's sort of the higher level of health technology assessment, or whatever you call that. Assessment of new drugs, assessment of new new technology equipment. So that, I think that's going to be interesting. We're seeing that starting to come in to the UK now, where it's been made very clear that all companies are expected to have some degree of life cycle assessment, environmental footprint of what's going on with their products. I think it's early days yet, Ian. It's going to be a while. I know Canada's sort of getting there. I know we're sort of getting there, but it's a little way away at the higher level. In terms of life cycles being part of practice, I think that, yes, and we're already starting to see that. Guideline generation, at least in anaesthesia in Australia, we've got a guideline of, using reusable equipment, go to the sources. Some of it is our work, some of it is Jodie Sherman. I know some of it, Seema Gandhi's, for example. So I think that's starting to come into play as well. I don't think we need to do too many life cycle assessments necessarily within anesthesiology, because we don't actually have that much stuff. We don't have as many toys as the surgeons. I do think that there will be a lot more is needed in pharmaceuticals, because it's very opaque there. And I think that more in other health technology as well.
I'm just going to take a question from the group here, and then we can move on to the other question in the chat. Any from the group? So in the chat, so just to give context, so Ron is the director of obstetric anesthesia, Ron George, at the Mount Sinai, which is the other big obstetric unit in the U of T group. And the question is about nitrous oxide for labor analgesia, moving from centralized pipelines to portable tanks.
Yeah.
Can we make an impactful change while maintaining access?
Look, that's really interesting in Canada because you're probably going to make much less of an impact than you would in Australia because you don't use as much.
But we're still piping.
But it's
it.
leaking.
Yes,
Leaking.
okay, now, yeah, that's an.
So
So I think that will make a big difference to no longer have a manifold or piped nitrous thereon, rather than having the little wheelie bottles, because you're no longer leaking anything. So yes, I think that's a great thing that you could be involved in.
It in London, Ontario, so at London Health Sciences, one of the healthcare engineers did a assessment. It will be almost 100% decrease in your usage, which is really just your leakage of nitrous by going to portable tanks. And those portable tanks will, for how much they would use, would only need to be switched out once every 2 or 3 months.
Yeah, just
So it's almost all
Yeah.
of it.
I'm just gonna chip in there as well. So there's actually quite good evidence now mounting all over the world, and there's no controversy about this, is that we've done this study at Sunnybrook as well, that more than 90% of all the nitrous is leaked. A very, very small percentage is actually used. So the solution, obviously, the interim solution while we still are using nitrous, is to go to at your site of consumption, having a small tank. That's the next step if you're not ready to say goodbye to nitrous yet.
Is there much leakage from the tanks? What's
There
the,
is some, but it's much less.
It's like 2 mils an hour
Yeah.
or something. It's almost
Gotcha.
nothing.
And part of that just relates to the number of connectors and
Yeah.
how long the piping is. It's just more opportunities for leaks.
There's nothing else in the chat. Anything there?
I, just because people drop off now, I want to say thank you to Forbes for taking the time while he was in North America to come up and visit us at University of Toronto, and they have put you to work today. I know that you've met with it, and tomorrow. I think the folks on the call don't know his schedule, but my goodness, thank you for your leadership, and Martin for his incredible leadership. And for the tremendous body of work that you've led. I want to comment about the impact of a single individual, and Martin at Sunnybrook has been so influential. I cannot pick up a blue pad now without Martin sitting in the back of my head going, do you really need that? Do you really need that? And
He's not even there.
there you go. And the nitrous story, I did not believe it. I couldn't believe it, but it's true. So I want to say that the power of an individual to make changes in an institution is incredible. And I know everyone in this room are game changers, as are you, Forbes. So thank you. Continue your leadership. We're very receptive to advice that you provide and guidance. And we hope that we can continue on your journey. Thank you.
But may I just have one question?
Sure. Oh, sorry.
Unlike you, I'm a mere clinician, not much of a researcher, but U of T, where I belong, is a research powerhouse.
Very, very big.
And I would love to see collaboration and what advice you can give to get people enthused in doing research in this space. Because we could bring so much knowledge to this.
So in fact, there's actually another reason for that is like the Dean of Medicine came out here last year, and that's why I have a job. It's a student at University of
And
Melbourne.
she met with our dean
Yeah,
for that.
and
purpose.
Fiona, for example.
Yep.
Sorry, I'm indebted financially to Fiona. Actually get paid for a little bit, so I do. And part of that actually is, I only became aware of it this year. There is actually a small grant that actually involves, because we're, I don't know, sister or brother universities, Melbourne, Toronto, and Manchester in the UK. And there's, I think it's something like about $5,000 to $10,000 Canadian, and a similar number in the other universities, so maybe $30,000 Canadian in total, to have projects that involve all 3 hospitals. And it can be in whatever field you want to be. I mean, it doesn't have to be anesthesia, it could be general medicine, whatever. So I think that is a really nice little, no one's actually ever making use of it. So it's just money that sort of just disappears. And so that it's not a large amount of money. And so I think that might be an interesting one. If someone wants to lead that, yeah.
We have a seed grant competition we're going to launch. It's a collaborative center,
Mhm.
up to 5 and maybe more, because Bisley Building partners $10,000 for partnerships, and so we will build more of this here collectively.
And if you want to lead that, please do, because I'm probably not going to. Yeah, it just for interest of time, but I've got to try and find someone who'll do it from my end as well, because yeah, and I've got good connections in Manchester as well. So yeah. Anyway, that's just a small idea.
Yeah.
I do think, as Anita has already shown, your wonderful leadership with your, dare I say, just stop signs. I think that's an enormous where we can actually be trying to catch up with you, because it's part of it is I just don't have the time to. So all of us don't have the time, so we've chosen certain pathways. Yeah.
If you're willing to go one more question,
Of
that's
course.
the last question.
Yeah. So Jonathan.
It's a big question about changing people's behavior.
Yeah.
Or air circulation.
Oh, sorry, I missed that one.
Okay. All right, we'll go to the air circulation first.
Yeah.
Yeah. All right. So Michael Friedland, yes, we certainly can. So what's interesting, and I should send it, it's coming out very soon in Deutsch. The Germans are coming out with a very interesting new, it's the anesthesiology infection prevention sort of task force, or whatever they call their group, Bundestag. And they're going even further and looking at actually just turning everything off overnight across the entire jolly country. And I'm sure they'll get there. So I think that's really interesting times for actually setbacks can happen out of hours. Now, I'm not saying that we all should just do that race and do it, but I do think there's real opportunity that I was seeing both in Australia and Canada and also in the US and many other countries for just turning hospitals at least down in terms of from 20 air changes an hour, which seems to be a pretty, standard minimum for most countries, down to 6 as an example. Why 6? Well, it's just a number. There's no actual real reason for it. And you talk to, so there's some engineers in the US and working with Jody Sherman and others looking at how we can try and do that. So I think there's enormous opportunity in that area. I think one of the tricky parts is actually getting the engineers within the hospitals involved. And I think it involves more of the actual faculty, university engineers as well in that process, because they have potentially a bit more time to do that. Once again, that involves a bit of money because you need someone's time to do it. And that might be a really interesting first project to do. I mean, I think it's just not even low-hanging fruit, it's rotten fruit on the ground. It's sort of like,
Anita's already done it, and
sorry, okay, well, it was already-
it saves money.
yeah, thank you, Anita.
Yeah, actually, Michael Friedland is from my hospital,
Okay.
and we're running a trial, and we will save our at our orthopedic center, and we will save about 65% of our energy and costs. That's more than half your costs. But what's really interesting is engineers love this stuff. They are the ones who are really interested in it because they do have to report back to leadership on what sustainability measures they have and how much they've saved, and they don't know this. And when we tested our brachytherapy OR, which is barely an OR, it's a procedure room, we're at 39 air exchanges an hour. And that room was used 6 hours a week. So there is opportunity everywhere for this.
So you said it's hard to get an environmental sustainability officer in hospital. Sorry.
Yes, and that's how much you say.
So there we go. So thanks, Michael. Yes, there's enormous opportunity. And that's fascinating, just hearing the 39 air changes an hour.
39
I don't know where that
air
comes from.
What's a glorified
Times 13.
procedure room? Brachytherapy is not a real, there's not like really.
No.
And what have you dropped it to? How many years? That was what it was,
No.
39?
So it will be 6 when we're not using it, which is
Yeah.
70 or 80% of the time.
And when you are using it?
Oh, yeah.
20.
20.
20.
Yeah, so thanks, Michael. Great question there. I think there's an enormous opportunity. The other one was about people's behaviour. What's the best way to change with chocolate cake? It's actually true. That's how I do all this stuff. I remember my first one was actually bake a chocolate cake and dip it into the central sterile supply department and said, "Hello, I'm Forbes. Would you like some chocolate cake?" And so, everlasting laugh. So, and that was good. But I think what was really interesting about that, it wasn't the chocolate cake. It was just the fact that I actually walked into a room with real people who were not nowhere near as well paid as I am as a medico, and actually took an interest in what they were doing because they said, your job is important, because without it, everything, the system would fall apart, because you pre-process everything we use in terms of reusable things. And just started to work out, oh my goodness, okay, so you do that. Why do you run those sterilizers that way? Oh, okay, gee, this is a whole PhD in itself. So it became the engineering part of my PhD. And it was just, we've had a great conversation after that. And so there's all sorts of other projects with. One of the really interesting ones, so I just digress, was was when we switched off the steam sterilisers out of canals, which was just another really obvious rotten fruit. And we saved 10 houses worth of electricity every single day from doing that. And then what was even better than that was Kaiser Permanente in California said, oh, we really like what you're doing. And they published a study, and that's really good with the publication because then it's becomes real. And they have saved 3 million kilowatt hours a year in their multiple US system of just turning their sterilisers off out of bounds when they're not being used. So you said it's really dumb. Yes, it is dumb, but it's just really good that it's actually changed now. So I got really excited about it. So there's like these sort of things that you don't expect are going to change things. And some things I've done have changed nothing at all, which has really been frustrating. But other things have really changed things quite dramatically that I weren't expecting at all. The Kaiser Permanente, as a result of that, saves about 300,000 US a year from doing that within their hospitals. Interesting. So, so what are the suggestions the best way? I haven't really answered your question, Jonathan. I think sometimes it is serendipitous. I think it's hallway chats. What we're hearing about that today, about hallway chats, and that leading to change in reusable equipment in Sunnybrook. And it's just, I think, being genuinely interested in what people do, I think, is really important. And don't pretend about it. If you don't really care about what people do, then do it. You're probably in the wrong game. But if you are, then just show your enthusiasm for what infection prevention is doing. How do we work together about this? What is a common ground we can get to here, if at all? And if we can't get to a common ground, can we talk to other people who might be able to get to a common ground? Like I mentioned, the reusable gowns. So I think that, Jonathan, it's just, I can't give you an absolute, there's no silver bullet again, but I think that changing people's behaviour is the vital story of this. It's not just about doing the carbon footprinting or whatever it is. Data are important, but I think it's much more than just data. Thanks.